Sure. For everybody. It used to be generic. It doesn't have to be that. So we could just make it for everyone. Right, everyone.
Voice projecting through the microphone. That's the reason. We could do both, but it kind of has a little bit of feedback. So this is what seems to work well. So yeah, the bathroom's in the back, and then the lending library. And anyone that's new, if you're not familiar with the livelifestylemedicine.com website, check that out. Sign up for the newsletter at the top of the homepage. This is actually our plant forward providers. So we have we'll keep that updated so you can check out if you're interested in seeing a community area provider that's plant forward, plant based, lifestyle medicine, board certified, that kind of a thing. And so I wanted to mention that. And then we have some other fundraising stuff in the back. So we're a 501c3 nonprofit called Based Providers that supports this Live Lifestyle Medicine program. And so we have a bottle, there's bottle drop you could do. We have some t-shirts, and then so we don't have a lot of overhead. It's mostly liability insurance, so we pay every year to be able to speak at different places. We speak here, many other places in the community, and so that's kind of it as far as that goes. And then so tonight I'm going to be talking about diabetes. And if you're also, since you're new to the classes, on the website, you can actually go about 2/3 of the way down the homepage. You'll see something there that says website tutorial. And if you click on that, it's about a 20-minute video of me kind of giving a tour of the website. So you can see all the resources that are there. You'll see the class archives that are there. So if this is your first class, you can go back to the start. I think this is week 6 out of 13. And you can go back to the beginning and actually just watch the recordings of all the classes. So to get caught up with everything. And any other announcements or anything before I get started?
Quick announcement. The Vegan Fest is coming up. May the 3rd? And so you want to attend that. Put it on your calendar. Also, Dr. Michael Clapper, internationally known speaker. He has a new book. The day after the Vegan Fest, he's going to be at the Vegan Fest, but it only holds 50 people in the room. So we've expanded. There's an auditorium of 800 people at the Springfield High School auditorium Monday night, May the 4th. Come out. Put it on your calendar.
1,500 people went to Veg Fest last year. So we're hoping for 2,000 this time. So the Eugene Plant-Based Providers Live Lifestyle Medicine, we're sponsoring the Vitality Room. So there's a Impact Room, which is more about environment, animal welfare, things like that. And then the Vitality Room is all health focused. So that's why we're part of that. So when we come to these classes, we do support, vegan events and things like that but it doesn't mean you have to be vegan to go or to come to class or anything like that. It's just we teach to eat a mostly whole food plant-based diet, a plant-forward diet. So diet centered around whole plant foods, fruits, vegetables, beans, intact whole grains, nuts and seeds, herbs and spices, and minimizing foods like animal products. So meat, cheese, eggs, dairy, added oils, processed foods. We're trying to minimize those. And it all depends on what your health goals are, where you are on that spectrum, and what your why for change is and all that stuff. So it's not you don't have to be in the vegan clique or anything like that to benefit from the community events we do and the classes and stuff like that. But we do tend to support other organizations, even though we're not a vegan organization. Eugene Plant-Based Providers or Live Lifestyle Medicine, we do support some of those area advocate for those area groups that do that. So just a little disclaimer there. And then the other disclaimer I always try to mention, especially when we have new people, is if you're going to make any of these dietary and lifestyle changes, you definitely want to be in contact with your medical provider, because your blood pressure could drop really low, especially if you're on blood pressure medicine, or if you're on diabetes medications that lower blood sugar. You need to really watch that, because food as medicine is very powerful. And I've had many patients over the last 13 years where I had to lower their blood pressure medications, their diabetes medications, their insulin, things like that. So their blood pressure wouldn't get too low, or their blood sugar wouldn't get too low. So definitely be in contact with your medical provider. So food is powerful medicine. Exactly. So before I get started, any questions or comments, anything, or I jump into diabetes? All right. So go ahead and switch to the PowerPoint presentation. All right. Next slide. So I've been a PA. The question is, how long have I been a PA? So I've been a PA since 2005. So over 20 and a half years now. And so, I switched. I won't bore you with my story, because you can watch the introduction class or catch it the next cycle. Is that I had my own health problems despite heavy exercise, and so I studied nutrition, and I ended up finding lifestyle medicine, and I got my health back by doing that. So I didn't have the food right. I was a heavy exerciser, had all the pillars of lifestyle medicine. I was good when I look back on it now, except for the food. I didn't have the food right. And so when I started moving toward a more plant-based diet, reversed my pre-diabetes, I dropped 47 pounds, my cholesterol dropped 100 points, my irritable bowel went away, my heartburn went away, just got healthy. And that was going from 7,000 miles a year on my bicycle to 3,000 miles a year on my bicycle. So with less exercise, I got healthy because I got the food part right. So that's my kind of my story there. Yeah. Yeah. You cannot exercise your fork. Cannot run your fork. So there comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. So that's what lifestyle medicine's all about. So, for Charlie tells the same story. Like I said, I've been a provider for almost 21 years. And, all I kind of was doing was, when I look back on it now, is just, treating symptoms with medications. And, you're just kind of overseeing somebody's medical conditions. You're trying to slow down the damage, and you're trying to make their numbers look better. And, these medications really make anyone feel any better. You're just treating symptoms. But what lifestyle medicine is, through the American College of Lifestyle Medicine, which I got board certified in, is basically treating the root causes of disease. So you're actually treating the cause of the problem. And so that of course, you still need to use medications sometimes, because people, you don't want them to have a stroke, or, their blood pressure is really high. And, it takes time sometimes to make these changes. And so think of the medications as a tool. It's not the only tool. It's just now, those of us that are board certified in lifestyle medicine, we have more tools in our toolbox now than we did before. So that's kind of the way I tend to look at it. So next slide. So we're going to talk about all these different things here. So most of our time will be spent talking about type 2 diabetes. That's 90-95% of all the diabetes. And then pre-diabetes, which is, we'll talk about these numbers, what A1C between 5.7 and 6.4%. And we'll talk a little bit more about that. Your fasting blood sugar between 100 and 125 is what pre-diabetes is. And then type 1, type 1.5, I'll kind of go over these briefly here in a second. Before I do that, though, I just want to give you, I'm going to give you the short version of my diabetes story before I talk about these different kinds of diabetes. So it was always kind of my interest area, specialty. One of my first jobs, we were actually encouraged, we had a really tight budget. This was in Salem. And we were encouraged to kind of refer within our practice, like this person over here, this provider here is really keen on women's health, and this one's really keen on autoimmune diseases or cardiology. And so we would still send people out when we needed to specialists, but we were encouraged to, so and so did a fellowship in cardiology, or did, has an expertise in a particular area. And so we would try to refer within our practice when we could, because it did kind of save money, and it's a good patient care as well, because you kind of kept everything in house. And so mine was diabetes. So I was kind of known as the diabetes guru because I just always went to the conferences, read everything I could get a hold of when it came to diabetes because I just really was passionate about treating diabetes. And so I was really getting into it, and then kind of the paradigm at that time, this is in 2005 to 2008 timeframe, and it was to really treat diabetes really aggressively. So try to get the blood sugar as close to normal as possible. So, essentially would be a fasting blood sugar below 100, an A1C of 5.6% or below, is where it would be considered normal. And so like someone that doesn't even have diabetes or pre-diabetes. So I was really using as much medications as I could, insulin, that I try to get people on aggressive treatment so we could get the blood sugar as close to normal as possible. And if you think about it, that kind of makes sense, right? If you have a blood sugar that's like someone without diabetes, then maybe you won't get the retinopathy, the disease in the eye, the high risk of heart attacks and strokes, and the kidney disease and the amputations and all the bad things that happen to people that have diabetes. And so that was the standard of care at that time. But then in 2008, there was a study, several studies that got published, a VA study, the ADVANCE trial, and the ACCORD trial. These were huge studies on diabetes. And I actually went to the American Diabetes Association conference in San Francisco in 2008 that year, and they were going to reveal all the results of these studies. And these studies were comparing people that were being treated aggressively, like I was doing for my patients in Salem, and then the other group was just kind of standard care, just kind of the way it had been up to that point. And they were going to see which did better. And it ends up 2 of those 3 studies, they stopped early because the aggressively treated group, it was killing patients. It was actually causing death. And some of the reasons were thought to be because you're driving the blood sugar so low because it was with medication, again, not treating the root cause, treating the blood sugar, it was causing a lot of low blood sugars, hypoglycemia. And so, it was a lot of times undetected, and that puts a lot of stress on the body. It's actually better to be slightly too high than to be too low. And we do this all the time to this day with patients, is trying to avoid doing whatever we can to avoid getting too low. And which is why I gave that warning at the beginning. And so that kind of the whole paradigm kind of got kind of uprooted and kind of turned on its head. It did show slightly decreased retinopathy in the eye, a little bit better on the kidneys for the aggressive group, but who cares if that's better? But if you're killing people, that's actually the worst, right? And so the reason I shared that before I talk about all this diabetes stuff is kind of wanted you to know where I'm coming from, because at that time, even though I didn't go plant-based myself until 2012, I knew that, well, this isn't the right way to do it, right? This is kind of, we need to rethink this as a medical profession. We need to rethink this. And so then we kind of backed off from doing that, but there's more and more drugs and things like that, which is a whole nother lecture in of itself. But I just wanted to share that with you tonight before I kind of go into all these different kinds of diabetes. So type 2 diabetes is caused by insulin resistance, and you're going to know more than you're likely going to know more than any of the doctors you've ever seen of what insulin resistance is, because it's just not really taught in medical school or PA school. I mean, did you guys learn much about insulin resistance, what it is, when you went to medical school and nurse practitioner school? Me for PA school? No, they're saying no. And so, yeah. A button for insulin resistance. Yeah. Anyway, so yeah, we're going to spend a lot of time tonight learning about what insulin resistance is. So that's what causes type 2 diabetes. And then pre-diabetes is also caused by insulin resistance. It's just your sugar hasn't gotten high enough yet. Your body's compensating well. You actually have tons of insulin in your body. It's just not working very well, but it's working well enough, and there's enough insulin that it's keeping your blood sugars from being high into the diabetes range. And so that's what pre-diabetes is. And it's estimated that over half of the American population actually has either pre-diabetes or diabetes. So it's really high. And 90% of people with pre-diabetes don't even know they have pre-diabetes. And then type 1 diabetes, we're not going to spend much time on that. That's autoimmune. So you used to hear that as being, childhood diabetes, or basically kids, teenagers, young adults tend to get that, and that's autoimmune. And what that means is your own immune system attacks the little cells called the beta cells in your pancreas that make insulin. And so you just don't make insulin anymore. And so you need to be on insulin. And so that's what type 1 is. But the key thing, we'll talk about it a little bit later, is that even with type 1 diabetes, you can still develop insulin resistance. And we know that that's maybe what's actually causing more of the complications. So even people with type 1 diabetes will often get amputations and eye problems and still at higher risk for heart attacks and strokes, all the same stuff that afflicts people with type 2 diabetes. But the reason we think that, actually, because you can have someone with type 1 diabetes perfectly controlled with an insulin pump and everything else, perfect blood sugars, but they might still develop all these other complications, because we think it's actually the insulin resistance that might be doing a lot of the damage. And so again, when we get to insulin resistance, you'll understand that. And then type 1.5, won't go into too much detail with that. LADA, it stands for latent autoimmune diabetes in adults. So it's kind of like somebody you thought probably did have type 2 along the way, but then all of a sudden they aren't really making insulin anymore. So they essentially become type 1 because they're either kind of their beta cells that make insulin burned out, or they had or some of their own immune cells came in and destroyed what was left of their cells that make insulin. And so then they essentially become like a type 1. So that's what type 1.5 is. And then gestational diabetes is diabetes during pregnancy. And so a woman will get the glucose tolerance test, they'll fail that, and they'll sometimes have to be on insulin or maybe metformin or some of the medications. But then usually as soon as they deliver the child, then the gestational diabetes goes away. But what we do know is that when you develop gestational diabetes, you're at really high risk of eventually developing type 2 diabetes. So it's a red flag there. Next, go ahead and go to the next slide. So here's some of the statistics. This is from the CDC from 2023. So 38.4 million in the United States currently have diabetes as of 2023, and then 97.6 million with pre-diabetes, and only, like I said, only 1 out of 10, it's like only 10% or 90% don't know that they have it. So 1 out of 10 only know that they have it. So that's between type 2 diabetes and pre-diabetes. That's 136 million Americans. So that's like a third of the population essentially has either pre-diabetes or diabetes. And then the direct and indirect costs, 413 billion as of 2022. Next slide. So it is, and we'll skip this video. It just talks more about the prevalence. But let's get into insulin resistance. But does anyone have a question about or want me to explain what A1C is and what it means? I showed you what the numbers are as far as what's the definition of prediabetes, diabetes. Does anyone want me to explain what A1C it means? Yes. Okay, great. So it's a percent number. So it's a percentage of what's called glycosylated hemoglobin. So best way to explain this is, so what happens if you take a steel box and you put it out in your front yard and it rains on it for off and on for like 2 or 3 weeks? What happens to the steel? What happens to it? It rusts, right? And so rust is oxidation, right? So oxidation is what rust is. And so we actually rust on the inside too, which is because it's called oxidation. But another type of oxidation is something called glycolation. So what glycolation is sugar attaches to protein. So all the proteins in your body, some sugar sticks to it. And so we have blood sugar flowing through our vein or our arteries and blood all the time, right? Because that's what we live on. As feeds our brain, feeds our blood cells, everything. And so hemoglobin molecules are a protein molecule. So our hemoglobin carries oxygen around the body and delivers it to all your tissues. And so your hemoglobin turns over about every 3 months. So every single hemoglobin molecule that carries oxygen in your body gets recycled and renewed about every 3 months. And so the longer that you have that hemoglobin going through your body, some sugar attaches to it. So normal is 5.6% of your hemoglobin molecules that are circulating in your body right now have a sugar molecule attached to it. So that's what the hemoglobin A1C is. And so it equates to a percent. The percentage equates to a number. So there is a chart, you can look it up online if you're interested. Like, 6.0 is like 130 or something like that, average blood sugar. So if you were wearing a continuous glucose monitor 24 hours a day, 7 days a week for 3 months, you would have a average blood sugar over that 3 month span of time. And that equates to a hemoglobin A1C percent. And so we use it because it's an easy way to track. And so we have goals like, 6.5 or higher is diabetes, 8% or higher is uncontrolled diabetes. We say, controlled diabetes is like in the 7 to 7.9%. We kind of usually fairly happy with that, when we're treating people with diabetes, and this is the standard. And so that's essentially what it is. And so, so that's why you can check it every 3 months. You always hear your doctor say, well, we just checked it a month ago. There's no reason to check it until 3 months out, because that's how long it takes to recycle all of those hemoglobin molecules. So there you go. Hopefully that helps you kind of understand what hemoglobin A1C is. Okay, so insulin resistance. So what is it? It's caused by the storage of fat in tissues that are not designed to store fat. So where are we designed in our bodies to store fat? Where do you think? No, where are we designed to store fat? So what's that? Well, not to store it. So I guess I should be more specific. So when we're storing it for the whole purpose of fat is to have calories for storage so that we can draw on those storages if we don't eat. So it's survival. So those of us that are sitting in this room today are here because that's genetically over thousands of generations. The people that have been able to store fat efficiently are the ones that survive, because we were a feast or famine hunter gatherer. So you would sometimes not eat for 2 weeks, but you'd have food available and you'd eat that, and then you might not eat for a week or two. So people that were always rail thin and don't seem to store any body fat, we all know people like that, right? Where they can eat whatever they want and they never seem to store any fat anywhere. And those people wouldn't have survived back in those days. So the people that really store fat efficiently everywhere on their body are that's a survival benefit, because you're going to actually have calories that you can draw from. And so yeah, I heard some people say abdomen, butt, hips. Right? You always hear about the pear shape versus the apple shape. So we know that pear shaped is better because you're storing fat in places that are not what we call metabolically active. So when you have the apple shape, you're putting a lot of fat in around your organs and places that it doesn't seem to be. It's more metabolically active. It has more inflammation tied to it. It's not as healthy to have the fat in the middle. It's healthier to have it in the hips, the thighs, and just kind of in the subcutaneous tissue. So that's where we're supposed to store fat. But what happens with insulin resistance is we actually store fat where we're not supposed to. Things like your muscles and your liver and your pancreas and your abdominal organs, that those places are not designed to store fat. And so, but we do. And some people think some of the theories as to that is it seems to be genetic in a way, because have you ever watched the show My 600-Pound Life, for the people that are like 600 pounds or more? Have you ever seen that? And so a lot of times you'll when you find out the medical history of some of these people, a lot of times they don't even have diabetes. They don't even have insulin resistance because they are not storing fat. They're storing fat where they're supposed to. And so if you think about it, to a certain point, that's not going to be beneficial, because you can't outrun the saber-toothed tiger. You can't climb the tree because you're so big, right? And so that's not a very, genetically, that's not very, fortuitous. And so some of the thought is that insulin resistance is a compensatory mechanism to stop storing fat in the subcutaneous tissue, start putting it elsewhere. But we're going to talk about that has consequences, though. And so, did you have a question? Yeah, fat around the heart even. Yeah, fat, yeah, all around all the organs and things like too. And it can compress and things like that. She's asking about or commenting about. So when we put fat in our muscles and our pancreas and some of these places, I'm gonna do a little demonstration and use this room as an example to explain why fat gets put inside places it's not designed to. So it's really caused by fat. So diabetes is not caused by sugar; it's caused by fat being in the wrong place, essentially. And so we'll talk more about that. So fat being stored in places that are not designed to store fat. So let's pretend that this room, this sanctuary, is inside of a muscle cell, because we actually can see. I'm going to talk probably more about it later too. Is that we actually have some of the reason we got some of this information is from studies that were done using something called a MR spectroscope, so magnetic resonance spectroscopy. And so what it does is it can show you where fat is. And one of the reasons we started doing research using this tool is because in a lot of countries around the world, especially Asian countries, they were getting type 2 diabetes before they were ever getting overweight. So they would look totally normal. Their BMI was normal. They looked normal, yet they have type 2 diabetes already. And in America, most people that have type 2 diabetes are usually 20 pounds, 40 pounds, 60 pounds overweight on average. And so that kind of made sense. Okay, yeah, you eat too many calories, you got too much body fat, you're developing insulin resistance diabetes. So that was kind of what we thought was 100% what it was. But with the Asian population, we were noticing no, they don't even have a lot of fat on their exterior, but they do research and they do these MR spectroscopes, and they can see where the fat is. Oh my gosh, look at this. This person has diabetes, they're normal weight, but look at all the fat in their liver. Look at all the fat in their muscles. Look at all the fat in their pancreas. That's a problem. And that's what insulin resistance is. And so let's pretend that this sanctuary is a muscle cell. And let's pretend like this organ here is a mitochondria. So did you guys take biology in school? So what is mitochondria? What do we call that? Powerhouse, the powerhouse of the cell, right? So think of this as the furnace. Think as the mitochondria is the furnace. It calls the shots. It's actually going to take the sugar or the fat. It can use both sugar and fat, and it's going to convert that into ATP, adenosine triphosphate, which is what creates energy to power our body. And so that's the furnace. Okay. And so then out in the fellowship hall where the books and stuff are, let's pretend like that is the bloodstream. So that's the bloodstream flowing through your body. And we're gonna talk about normal physiology. Then we'll talk about how insulin resistance works. So the blood's flowing out there. There's some sugar in there because you just ate some food, and there's always some sugar out there. But there's a little spike in sugar because you just ate a meal. And so then basically insulin then gets released by your pancreas, goes and knocks on the door and says, "Hey, mitochondria in the cell, we got some extra sugar out here. Can we come in?" And the mitochondria says, "Yeah, sure, come on in. We got a little bit of sugar in here. We got a little bit of fat in here, but we can use some more. Come on in." And so the insulin unlocks the door, opens it so the sugar can come inside. That's normal physiology. And then the furnace will burn up some sugar, it'll burn up some fat, and fat doesn't need an invitation to come in. It just comes on in whenever it wants. It just barges in. And so there's this balance that we use. And so we can use a little bit of fat, a little bit of sugar, make that ATP, everything's hunky dory. But what happens with insulin resistance is if you're eating tons of bacon and sausage and McDonald's and all the high fat, especially high and saturated fat foods, you're eating tons of that, kind of the standard American diet basically. And let's just say you're predisposed genetically to something like type 2 diabetes, prediabetes, which we know that a lot of us are, a third to half of the population, right? And so what happens then is, like I said before, the fat doesn't need an invitation. So the fat that you just ate in that really fatty meal, especially saturated fat, it's coming in here without a permission. It just comes on in. So there's tons of fat in here now, and you can see it on that MR spectroscope, which I talked about, because you can see it when you see the fat in here. And so that's what's happening. You got all this fat in here, and now the sugar is still out there because there's also obviously lots of sugar too out in the bloodstream because you just ate. But there's all this fat in here. And so now the insulin knocks on the door. Hey, mitochondria, there's a lot of sugar out here. Can we come in? And the mitochondria, what do you think the mitochondria says? No, you can't come in. We got so much fat in here, we got to burn up first. No way, you're locked out. And so the sugar gets stuck out in the bloodstream. So now your blood sugar is going high because you have all this fat in here you got to burn up first. So what happens, you start, switching to a more whole food plant-based diet. You start getting rid of the meat, the cheese, the eggs, the dairy, the oils, all the processed junk. It's loaded with fat and calories and all the excesses. And so you start getting rid of those foods and transitioning toward a more whole food plant-based diet. And even with plant-based fats, they can clog up in here too. If you're eating tons of olive oil, maybe like say you ate a whole bag of nuts or something like that, which is really high in fat. You're eating like 3 or 4 avocados a day. So you can go overboard with plant fats too. And that'll clog up in here too, just like the animal fats. But the animal fats are especially deleterious. So especially the saturated animal fats create a lot of toxic end products, ceramides, and all these kinds of things. And so you still got to be careful with the processed plant foods and too much fat in from the plants too. And so, but you go on a low fat, whole food, plant-based diet, fruits, vegetables, beans, intact whole grains, no more than like a handful of nuts and seeds, and you're eating a really healthy diet. What's going to happen over time? It could take sometimes it only takes a couple of weeks. Sometimes it takes a few weeks. Sometimes it takes a few months. I've had patients it's taken up to a year to get rid of all the excess fat. And so if you're eating all this really healthy food now, and eventually all this fat gets burned up in here, and it goes back to the first scenario where, oh, there's not very much fat in here. Okay, insulin, you can open the door and let some sugar in now. And then and I see this happen in real time with patients where, someone that was on 100 units of insulin a day, now maybe is only on 20 units. Or I've had patients that had A1Cs of 14%, really terrible, on insulin, on multiple diabetes medications, now no longer have diabetes. They're not on, I was able to take them off all their insulin, all their medications. They're diabetes in remission. We don't say cure, because if you went back to your old diet, it would just come back, right? So that's not really a cure. It's a remission. So American College of Lifestyle Medicine has the term as diabetes in remission. And actually through our EPIC chart system, ACLM was American College of Lifestyle Medicine was really a leader in a leadership role with this. There's actually now a diagnosis code for diabetes in remission. So that's a win. So it's happening enough that's what happens. So any questions about what insulin resistance is? Does that make sense? So yeah, and I actually can show a video that has a cartoon showing this, but it's kind of overkill if you've already kind of understand it. So what it causes insulin resistance and type 2 diabetes? Is it carbs and sugar, or is it fat? It's fat, right? And so it doesn't mean eating more sugar is good, because it's just empty calories and causes inflammation, and it's not good for you. But so sometimes I have patients that will say, "Oh, I have diabetes. I can't eat fruit." It's like, well, yeah, you can. That's in a whole plant form. It's bound to fiber, tons of water, vitamins, minerals, everything, antioxidants, everything you need. And when I do calorie density in a couple of weeks, you'll see a comparison. Like there's the same amount of sugar in 3 ounces of gummy bears that there is in a 2-pound pineapple. They have the same amount of sugar, but one is a 2-pound pineapple, perfect for you. The other is just sugar by weight, because it's just gummy bears, right? And so they have the same amount of sugar, but it's the package that makes the difference. So gummy bears aren't good for you, but pineapple is good for you. So if you have diabetes, you want to eat more pineapple, but not the gummy bears. But another study to kind of hammer this home is actually, this was a study done in 1928. So in 1928, it's called the Sweeney study. And what they did is Dr. Sweeney did is he took his medical students, they're so young 20 something kids, they're medical students, and they had one group that, and it was a totally unhealthy diet. It was like maple syrup and white sugar and white rice and white potatoes and it was low fat but all sugary food, and so not healthy. And that was in one group, half the class. The other half did like pork and cheese and really high fat. And so and these are normal people, normal kids. They don't have diabetes, pre-diabetes, nothing. And he I can't remember how long each of the groups ate that food, but then he did a glucose tolerance test. I think it was like a week. It was only like a week or two. And he did one of those glucose tolerance tests like you do for women that are pregnant. And guess which group failed and which group actually was normal? The sugar group was normal. So the people that were eating junky, sugary, so no fat at all, but just sugary food, they passed their glucose tolerance test just fine. The people that ate the tons of fat, they failed their glucose tolerance test. So that example, so that just from eating that food for a week, all that fat came inside the cell, blocked the insulin, so it wasn't working. So when you know you have insulin resistance is when you fail the glucose tolerance test. So you have poor insulin sensitivity because that insulin was knocking on the door. Hey, can I come in? No, you can't come in. That means bad insulin sensitivity, insensitivity, right? And then, so that's what would happen. So even back in 1928, we knew it wasn't sugar, it was fat that was causing diabetes. But you think, nobody really paid attention or got that. So you still to this day will hear providers, dietitians, doctors say, "Oh, cut the carbs if you have diabetes." It's like, and I'll talk about what it's called the keto caveat here in a little bit, but I just kind of wanted to kind of give you that example. And then, so why is insulin resistance so bad? So go to the next slide. Because insulin resistance influences all of these things. So coronary artery disease, which is heart disease, cancer, all the types of diabetes, type 2, type 1, type 1.5. And so I'll stop there for a second because patients with type 1 diabetes, I've had patients that, because they're eating the standard American diet or even a low carbish kind of a diet, because that's what they were told to do. And they are on more and more insulin, and their carb to insulin ratio, which I'll talk about again here in a little bit too, is really poor. And so that means they have lots of insulin resistance and poor insulin sensitivity. And so that's how you know you have insulin resistance. And so insulin resistance, so that's why we think, because a lot of times people with type 1 diabetes will also have all the same complications because they can also have insulin resistance. So it's like someone eating a standard American diet that has type 1 diabetes, it's like they have type 2 also because they have insulin resistance also. And so that's double diabetes. It's really bad. It's really bad. And so when you have no insulin resistance, especially with the type 1, it's easy to tell whether they have insulin resistance or not, is to know what their carb to insulin ratio is. So if they say they only need 1 unit of insulin for every 4 or 5 grams of carbs that they eat in a meal, that's really great. That means they probably don't have any insulin resistance and they have good insulin sensitivity. Whereas I have patients with type 1 that are on like 80 to 100 units a day, and their carb to insulin ratio is like 20 to, or no, I'm sorry, I said it backwards. So their carb to insulin ratio is like 2 to 1, 3 to 1, 4 to 1. That's really bad. And so, because you need a lot of insulin to cover a certain number of grams of carbohydrate. So I said it backwards. But then if you don't have any insulin resistance, your carb to insulin ratio is really good. It's like 20 to 1 or 40 to 1, 30 to 1. So you only need 1 unit of insulin for every 30 to 40 grams of carbohydrate. So that means, you have little or no insulin resistance and good insulin sensitivity. So yeah, sorry, I said it backwards. But then prediabetes, chronic kidney disease, Alzheimer's disease. So Alzheimer's disease, another name for it is insulin resistance of the brain, or type 3 diabetes. It's actually also been called. So one of the 3 key mechanisms in Alzheimer's disease is glucose dysregulation. So not having good ability to deal with sugar in the brain is part of insulin resistance. Fatty liver, which makes sense, right? Because where do we store that fat? In the muscles, in the liver, in the pancreas, things like that. Your cholesterol, blood pressure, obesity, polycystic ovarian syndrome is actually also tied with insulin resistance. So you'll see some women that have polycystic ovary syndrome, they don't ovulate, they can't get pregnant. And of course, they have excess androgens and some other things, hair growth and things like that. That's part of it too. But they also, a lot of times, if you can treat someone with polycystic ovarian syndrome with a healthier diet, sometimes you'll see they'll get put on something like metformin, which is a diabetes medication. They'll start ovulating because you actually started to reverse their insulin resistance. So that's part of it. Neuropathy and retinopathy. So neuropathy is the pain in the, like in your feet, retinopathy in the eye, erectile dysfunction. That's also related to insulin resistance. So you can see how important it is. And so when I talk about the keto caveat in a little bit, you'll understand, you'll kind of remember this slide when we talk about why is it important to treat insulin resistance, because you could be on all the diabetes medications in the world, like I was doing with my patients back in 2005 to 2008, but you're still not treating the insulin resistance. You're just lowering blood sugar. So for a diabetes medication to be actually approved by the FDA, it doesn't have to show it can do anything other than lower blood sugar. That's all it really has to do. Some of the newer expensive medications do lower insulin resistance a little bit, even the GLP-1s do. And so but then they have, they're expensive, they have side effects. So it's not always the best choice, but there are some better ones than there used to be. Then like a GLP-1, if you stop it, then you lose all the benefits and everything comes roaring right back. But so go to the next slide, and advance to the next slide. Go ahead, and we won't play it. I think I'll just keep going. Okay. So you might be wondering, so how many people in here, know someone that, does a low carb diet, ketogenic diet, carnivore diet, paleo diet, right? And different people's hands come up. And so you'll hear, well, okay, so, and I followed a low carb diet, the Atkins diet, about 25 years ago. I did for about 3 years, because at that time we didn't have any long-term studies. All we had were short-term, like, after a year, you lost this much weight, your blood pressure went down this much, your cholesterol went down this much, your blood sugars improved. And so, hey, it looks pretty good. So, and I like eating that food or whatever. So I was like anyone else. I wasn't educated about nutrition or lifestyle medicine like I am now, but I drank the Kool-Aid. I followed it for 3 years and lost some weight. And so I understand. So I have patients that come to me doing low carb keto. And so I don't throw them under the bus, because at least they care about what they're eating. They care about making change. This is someone I can work with. So I actually don't mind that at all. But then sometimes you'll hear, okay, well, so when I went from the standard American diet to a low carb diet, high fat, high protein. So what does low carb mean? Well, if you're getting less than 20 to 30% of your calories from carbohydrate, usually it's sometimes even as low as 20 to 30 grams. You can try to be in and out of the ketosis ketones you produce, because your brain can only use sugar for energy. And so what ketones are fat. You're basically, when your body breaks down fat for energy, it produces ketones, and ketones can go to the brain and actually provide energy, because your brain can't use fat for energy. And so anyway, you have this situation happening. And so when someone that has diabetes goes on a low carb, like a more keto kind of a diet, their blood sugars go down, they lose some weight, their blood pressure can drop, their insulin requirements sometimes will go down significantly. So on paper, it looks really great. Like, wow, everything looks better. Your numbers all look better. You're almost like sometimes I'll even hear people from the low carb camp say, well, yeah, we put diabetes in remission too. It's like, well, there's a problem with that, because what we show from studies is that you haven't treated the insulin resistance at all. I mean, if you lose a certain amount of body fat, there is a slight decrease in insulin resistance just from losing weight. But then when you stop losing weight, which we all do at some point, hit a kind of a plateau and whatnot, then all the benefits that you saw in someone on a low carb diet usually go away. So once you've stopped losing weight, your cholesterol starts shooting up, your blood sugars can sometimes shoot up, but sometimes they don't because you're eating so low in carbohydrate that there's not very much blood sugar out in that bloodstream out there, that example we gave, right? So if there's not very much sugar in the blood, then your numbers will look better, and you might not need as much insulin because there's just not that much sugar out there. So the knocks on the door from the insulin are not as loud because, hey, there's not that much sugar out here. We don't need to get that much sugar to come in here. And some of the fat that you're eating is coming in here and getting burned up for energy too, and producing those ketones and whatnot. And so keeping carbohydrates low will stabilize and lower blood sugar, A1C, fasting insulin, insulin requirements, fasting blood sugar. Those will get better, but that's incomplete information about the presence of insulin resistance. So what did we talk about earlier is what's the best test for insulin resistance? Wasn't it that glucose tolerance test we talked about, right? So the glucose tolerance test or carb to insulin ratio. So if you're not on insulin, you might not know how to figure out your carb to insulin ratio. And so the best way for a normal person to know that is, and I have this happen all the time, or you might have heard this before, is like, oh my gosh, or they have their glucometer or whatever, and they say, yeah, when I ate that fruit, or when I ate those beans and rice, my sugar went through the roof. It really shot up. So I shouldn't eat that, right? That's what your reflex would be, wouldn't it? If you're eating fruit and beans and rice, oh, I should stay away from that because my blood sugar shot through the roof. That just tells you right there you have insulin resistance, poor, because the goal is to be normal physiology. The normal physiology is if you have no insulin resistance and high insulin sensitivity, you can eat fruit and beans and rice and your sugar will spike a little bit because it's supposed to for 100% of us, just to trigger insulin release so that sugar can then go into your cells to be used for energy, right? And that's what the whole purpose is. And so if you eat those foods and your sugar shoots through the roof, that just tells you have insulin resistance. And so when you take someone that's on a low carb keto diet and you give them a glucose tolerance test, or you challenge them with carbohydrate, with fruit and beans and rice, they usually fail miserably because they're hiding their insulin resistance. So it hides insulin resistance. And so we remember from that slide, I told you to photographic memory and remember all the bad things that insulin resistance does. So that's still happening. It's in the background. You just don't know it. So someone on a low carb diet will actually have this. And again, a lot of the things that were hidden are partially hidden by the weight loss. So if you take somebody and you put them on cancer chemotherapy. So this is a little bit of an exaggeration, but if you put someone on cancer chemotherapy, they lose their appetite, they get sick, right? And so they lose weight, their blood pressure drops, their cholesterol drops, their numbers will all look better on paper, just like a keto diet would, but you're not healthy, or you're just sick. And ketosis and being in a low carb ketogenic state is actually a mild form of illness. It actually suppresses your appetite. I mean, it's a normal physiologic process that we have to help for famine, for fasting, because remember, if you don't eat for 2 weeks because we have all this extra body fat, our brain can't use fat, and so it has to break down the fat, make ketones, go to the brain. And so it is a mechanism that we have to survive, but it's not designed to be sustained. It's actually just designed to be there for emergencies when we need to survive because we don't have any food for a week or two. And so that's one aspect of it. So glucose tolerance test, carbohydrate insulin ratio are the more complete markers of insulin resistance and insulin sensitivity. And then the other thing I have to tell colleagues this sometimes. And so play this experiment with me. And so I pretend like you're my medical colleague. And I say, okay, and maybe Charlie and Nathaniel can chime in. So what's the number one cause of death for an American in this country? What is it? No, I mean, so a medical condition. Heart disease. Yeah, good job, you guys. Yeah. So yeah, heart disease, right? So heart disease is the number one cause of death for an American. So what's the number one cause of death then for someone with diabetes? Also heart disease. And we actually know that someone with diabetes has the same risk of having a heart attack or a stroke as someone that has already had a heart attack or a stroke. We call it a risk equivalent. And so that being said, as my medical colleague, what do we know that are the foods that cause heart disease? Fat, eating saturated fat, eating lots of animal products, processed foods, pretty much the foods that we as Americans are eating are the foods that are on the food pyramid that just came out. Lots of meat, lots of cheese, whole fat dairy. That's actually, and there's no debate about that whatsoever. You ask the American College of Cardiology, the American Heart Association, the class we just had last week on heart disease with our cardiologist, Kristen Linsmeyer. If you were here last week and if you missed it, watch the recording that's on the website right now from last week. What do we want to tell patients to avoid heart disease? Avoid saturated fat, avoid animal products as much as you can. It doesn't have to be 100%, but try to reduce those. But what is somebody mostly getting their calories from if they're on a low carb diet? It's meat, cheese, eggs, dairy, full fat dairy. It's all the high protein, high fat animal products. So you're telling someone with diabetes who's already at super high risk of having a heart attack or a stroke to eat more of the foods that actually contribute to heart attacks and strokes. And so it doesn't. So when I tell a colleague, well, what I do that thought experiment, and they just go, oh, that doesn't make sense. Why am I happy about someone on a low carb diet? Yeah, their sugars went down and they look better on paper, but they're eating foods that are going to contribute to what's going to be the number one cause of their death. And so to me, that would be malpractice. That would be negligence. But it's a disconnect, So did you have a question or a comment? Yeah. Right. So keto, because they're going for a lot high protein, so they're also getting high fat because we only have 3 macronutrients. We only get calories from 3 sources: protein, fat, and carbohydrate. So that's where the disconnect is that so if somebody's going for protein and fat, they're usually choosing animal products because then they're low, because those are really low in carbohydrate. But then they also know that, but I should be eating lots of vegetables because vegetables are healthy, right? And so there's that disconnect because what are mostly vegetables are mostly carbohydrate, right? Healthy carbohydrate. But so it's kind of like we know inherently that we should eat plants because they're healthy for us, lots of fiber and everything else, but that's mostly carbohydrate. But then if you're choosing to go for high protein and high fat, because that's what you need to do to be low carb, is that now you're getting all the other bad stuff that comes with it, and you're avoiding the foods that are the highest in phytochemicals, phytonutrients, vitamins, minerals, antioxidants, everything we need to be really healthy. You're avoiding those foods and eating the foods that are contributing to our number one killer. So, yeah. Go to the next slide. All right. Well, but before I talk about these other 3 pillars, any how it and its effect on diabetes, any questions about insulin resistance, anything that we've talked about so far? Are there any questions in the chat at all, Ed? So anyone have a question about anything we've talked about so far? So you already know more about insulin resistance. Yeah.
When people exercise, does the fat around their organs or that stores in the unusual place burn the same way as your regular fat?
That's a great question. So the question was for those online is the fat that's in the bad places, in the muscles, in the organs, in the central fat, does that get burned differently than the fat that's out in the storage? And actually, luckily, our body is smart. It knows that the fat in the muscles, the liver, the organs, and the central is worse for our health than the fat that's out here in the subcutaneous tissue. So luckily, it does predominantly burns the fat in the bad places first. So that's great. Our body's smart in that way. And so, because that, if you always think about, gosh, I've lost all this weight and everything, and my numbers look great and I feel great, but gosh, I sure can't get rid of that fat here or on my butt, or, I can't get rid of that stubborn fat, right? And that's what your body really wants to hold on to, because that fat's not really hurting you. It's in a place that's not very metabolically active. It's not very inflammatory. So fat is actually an endocrine organ. It actually secretes inflammatory markers and all kinds of things. But that unhealthy fat is even more so that way. And that's why, we store excess, toxins there. We just store excess hormones and things like that there. So we want to, ideally want to get rid of any excess fat, but and it's also very genetic, and there's a lot of other things that influence body fat, hormone levels. Like women after menopause, it's really tough to lose body fat because estrogen was protecting you, and when estrogens go down, your insulin resistance goes up, even when you haven't changed anything about your diet or your lifestyle. So it's a obesity is a very complicated chronic condition, and it's not just calories in, calories out, what you choose to eat. I mean, yeah, what you choose to eat and how you move and the 6 pillars of lifestyle medicine have a huge influence, but there are many people that still, for just so many other reasons, hormones and so many other, and things we don't even know about, toxins in the environment and all the different things contribute to whether or not we can get, be at an ideal weight, and everyone's a little bit different. So that's a whole nother topic. But yeah, that's a great question about the fat. Is that what you were looking for? Okay. Yes. So they have questions about visceral fat. So BMI is a terrible thing, and we kind of really don't use it that much anymore. I mean, I've started taking obesity off patients' problem lists, BMIs and all that, because the newer studies are showing it just doesn't really reflect whether you're healthy or not. And you can have a normal BMI and be very metabolically unhealthy and have all that insulin resistance and everything we just talked about, because it doesn't really show up on a BMI necessarily. So visceral fat, the only kind of the most ideal way to check for visceral fat, which is the fat in the center and around the organs, is you can do that MR spectroscope and see where the fat is, but that's very expensive. It's kind of more in a research phase. You can also do, basically measure your abdominal girth, and so you go above the navel and do basically a waist measurement, and that's a little bit better than BMI. It's definitely better. And then you can do body fat percentage in a water tank and different things like that. But, I think most of us would just say, hey, look in the mirror. And for the most part, I'd probably say 90% of people just looking in the mirror, okay, I have some extra fat in my central area. So maybe I should, work on that. And then knowing what your blood pressure is and your blood sugars are and all those other things can be helpful. But yeah, like I said, there's people that, rail thin, but they still have diabetes. They still have insulin resistance because you can't see that fat necessarily. So yeah. And so, yeah, I want to talk about, exercise, sleep, and stress. So these also huge influence on diabetes and overall health. So exercising muscle, remember how I talked about the fat in the muscle here and in this whole scenario, when you have muscle that's been exercised, it actually takes little to no insulin for sugar to come inside. And so it kind of is like a bypass. And it can be for up to 3 days even. So up to 3 days after like an hour of exercise, walking or bicycling or playing tennis or whatever you're going to do, that's moderate intensity exercise. And we kind of go over that a little bit in our physical activity course at the end of the series, for a full 3 days after you've exercised your muscles, they're more sensitive to insulin. So sugar can come in much more easily. And so up to 3 days after you've exercised, it's easier for sugar to come inside your muscles, and so without very much, if any, insulin. So that's why that's very important for treating insulin resistance and diabetes. And then sleep. So if we're getting good restorative sleep, that's when we're really detoxifying our body and everything's recycling and all the toxins are going away. And if you're not sleeping well, we secrete extra hormone called cortisol. So cortisol is a stress hormone, like a steroid basically. And when cortisol levels are high, your body holds on to fat. You have more insulin resistance. So everything that we talked about that's bad happens when we're stressed, when we're not getting good sleep, and then if we're not exercising, it's a triple whammy. So you want to eat that whole food plant-based diet. You want to get good exercise. You want to get good sleep and stress management, good social connection, coming to classes, things like that, interacting with each other. All these things are so important to kind of all the pillars of lifestyle medicine work together. So, eat more plants, stay calm, cultivate connection, keep moving, sleep well, avoid risky substances like alcohol, tobacco, recreational drugs. All those things work together. Because think about it, if you didn't sleep well last night, you had a really stressful day, are you probably going to want to make a healthy food choice? No, we're not going to be in our frontal lobe of our brain. We're going to be in our amygdala, which is our kind of our area that's like, just make me, I want to feel good. Dopamine. I want dopamine. I want to just feel good. I want to be soothed. The amygdala part of our brain in the center of our brain doesn't care about our health goals or what we want out of life, our purpose, our meaning, our pleasure when it comes to things that have value to us. It just wants what it wants right now. And so when we're poor sleep and we didn't exercise and we're stressed, we reach for foods that are going to make us feel good. So we're going to reach for things with high sugar, salt, fat, things that are processed. Does anybody go to 7-Eleven at 2 a.m. to get like bananas or broccoli or whatever they have there? We're going to get ice cream. We're going to get chips and things that just going to flood our brain with dopamine. That's what we want at that time. But when we are eating a healthy diet, when we're getting that exercise, when we're sleeping well, when we're being mindful and being, kind to ourselves and all these things together, all what that does is then now we are in our frontal lobe. Now we do care about why we're doing this. What's our purpose? What's our meaning? What do we get up in the morning for? What our goals are? We can stay in that part of ourselves. And that's really our true self. When we go back to what the brain just the amygdala wants, that's not our true identity. That's not who we are. That's just chemicals saying, I want to feel good right now because I'm stressed. And so, and I talk a little bit about, I actually had a whole class before on food addiction, and I'll probably bring that one back at some point. It's in the old archives if you dig back and want to see. I have a whole class just on food addiction because there's a lot of science on that too. But so yeah, further questions, anything we can talk about? Yeah. Oh, sure. Yeah. So the question is, how does diabetes lead to kidney disease? So it's almost like anything with where blood flows. And so and we have there's so many different mechanisms that cause damage to the body. So high blood sugar also does damage because, it basically it causes lots of oxidation, that rust example we talked about earlier. And so having high blood sugars, we know damages the little blood vessels that feed the kidneys. So that was what her question was about the kidneys, but it would do the same thing to the eyes, to the nerves in our feet. And so we don't heal well, all these kinds of things. So having too much sugar also is very caustic to the body. And so it damages a little. So pretty much what's amazing about the kidneys and why we can live with one kidney or even half of a kidney and can donate a kidney, it's because every cell in your kidney is a little kidney. Isn't that amazing? And so every little cell has its own system, and so it can function as a kidney. So you don't need a kidney as a whole to do its job. Every little cell in your kidney, nephron is called, can do the job of a kidney. So pretty amazing. And so and they're so tiny, and there's little blood vessels that feed all of those. And so if you have a lot of oxidation and inflammation and high blood sugar, all these things, it's going to start damaging those little blood vessels. And so when those blood vessels are damaged, the blood supply and nutrients and oxygen and stuff's not going to get to those little tiny little nephrons. And so those little nephrons are going to start dying. And so and then there's something called hyperfiltration, which is just you're overworking it. Like you're paying them $2 an hour. You got to work, 18-hour shifts. You got to increase your production. So you're very demanding. You're a horrible boss, and you're just labor, and they're going to want to strike at some point, right? They're going to walk out or they're going to strike because they're not happy. And that's what we're doing with eating the standard American diet, not sleeping, all those 6 pillars of lifestyle medicine. We're causing that to all be in a bad way. And there's involvement with the sympathetic nervous system. It's chronic oxidative stress and inflammation and all these things. We talk about chronic inflammation a lot in these classes versus acute inflammation and stuff. So just think about it that way. And so basically you're just destroying the tiny little kidneys, and eventually you end up, the number one cause of being on kidney dialysis is from diabetes. But the thing is most people, because the average person on kidney dialysis only lives about 5 years, that's the average. And part of the reason for that, and the part of the reason that there's not more people on dialysis, I mean, there are other kinds of kidney failure, autoimmune and IgA nephropathy. There's all these other kinds of kidney problems that people go on dialysis, but mostly it's from diabetes. But most people die before their kidneys get so bad they need dialysis. And so, because think about it, what's the number one cause of death we talked about? Heart disease, right? And so, most you're doing that same damage to all the blood vessels that feed your heart muscle. And so, most of the time, you'll end up dying from a heart attack before, because remember, all those little tiny kidney cells, it takes a long time to destroy them all so that you need to be on dialysis. And usually, there's so much damage being done to your other organs and your heart that you die from a heart attack before you ever lose so much of your kidney function that you have to go on to dialysis. And just as an example, I had a patient, I always bring him up. He was seeing me for his diabetes for lifestyle medicine. And I was able to get him off his blood pressure medicine, his diabetes medicine. He was essentially put his diabetes in remission. But the other reason not reason he was seeing me, but it was just a benefit that he experienced was he wasn't my patient, he was referred to me, and he actually had his GFR, if you know what that number is, it's a glomerular filtration rate. And so anything over 60 is considered normal. I mean, we say 60 to 70 is like, stage 2 chronic kidney disease, because you want it to be high as possible, like 90 to 100. But most people that are in this country are in the 60, 70 range, which is, still we consider fairly normal. You're not going to really have any symptoms. Everything's probably going to be okay. Anyway, so his was down at 18. And usually if you start dropping below 20, get close to 15, that's when you got to be on dialysis. So that's really bad. And so he was already referred by his medical provider to go see nephrology, to go see the kidney specialist, and he was going to be getting set up for dialysis. And so, but he was doing all this with me for the diabetes. And it's 6 months later, by the time he had already kind of reversed his diabetes with me, and he'd lost a bunch of weight and got really healthy, by the time he actually got in to see the nephrologist to his appointment, by the time he showed up, his GFR had gone from 18 to 44. And so it more than doubled his kidney function. And so, because he was switching from animal protein sources to plant protein sources. So animal protein is much harder on the kidneys than plant protein. Plant protein, for whatever reason, we don't know all the mechanisms. For whatever reason, plant protein is just easy peasy for the kidneys to deal with. So our kidneys filter out our blood. And so when we break down protein, there's nitrogen there, and too much nitrogen is toxic. So our kidneys get rid of it. And so his kidneys weren't getting rid of it very well. And so it was damaging his kidneys. And he got down to the 18, but then he switched from animal protein to plant protein. And of course, all the other benefits he was getting went up to 44. So the nephrologist is like, what are you doing here? I don't need to see you. And so then he came back and, no, I don't need dialysis anymore. So it can be really effective. So then you had a question? Mm-hmm. Mm-hmm. Yeah. So the question is, didn't know that fat causes inflammation. So yeah, you can actually measure. So when someone has a certain amount of body fat, you can do in research, you can measure. We have different blood markers for inflammation. So C-reactive protein, SED rate, other cytokines, and there's all these other inflammatory markers we can measure in the blood. And so when somebody loses body fat, those tend to go down. And so they put out, so body fat is, like I was mentioning earlier, is an endocrine organ. So it produces different inflammatory products get spilled into the blood. And so we know this. And so so that's why having too much body fat's not good. And so even some of the even though the visceral fat's the worst, like we talked about, even some of the subcutaneous fat, if we have too much of it, also produces extra inflammation in the body. So there's lots of things that cause inflammation in our body. So not getting sleep, being stressed, eating the toxic standard American diet, all that stuff contributes to chronic inflammation. So acute inflammation is like you get a cut on your arm, you scraped up against the barbed wire fence, you got a cut there. So it's going to get red, it's going to get swollen, it hurts, right? And that's basically your body, then your immune system goes to that site, makes it red, increases blood flow to that area. All the white blood cells start going there to start repairing it. And the inflammation is actually there to protect it. So it hurts because, oh, now I need to protect that area and keep it clean or whatever so it doesn't get infected. So that's all part of the normal process. And that's acute inflammation. So that we need that. So that's why inflammation is good in that scenario. But when we have chronic inflammation, which is usually low level inflammation, that's just like the pilot light burning all the time. The house is always on fire. And so when the house is always on fire, that's bad. So chronic inflammation is not a good thing. And it's involved with pretty much every chronic disease we have. Chronic inflammation plays a major role. And so having excess body fat also contributes to that inflammation in the body. So that's why we want to, try to lose some of that body fat if we can, especially that metabolically active visceral fat, the central fat, the fat in the muscles and organs and things like that. So yeah, does that answer your question? Yeah. Right. Inflammation. Yeah. 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 Hmm. Right. No, it's so the question is when you lose body fat, do you get rid of the fat cells? No. The only way you can get rid of the fat cells is if you have liposuction or have surgery to remove fat. And so that's the only way to lose the fat cells, but they do shrink and they do expand when we keep storing more and more fat. We tend to add more and more size to those fat cells. Yeah. Mm. Okay, sure, sure. Yeah. Oh, in the back. No, I'm not sure. I'm not sure if I know that answer to that question. Yeah, does everybody have the same number of fat cells? Because it's more fat mass, but I guess I don't know if we're born with the same number of fat cells. I don't know the answer to that question. Yeah, yeah. Well, from Yeah, it's what so excess calories was always going to, some people are better at storing excess calories than other people. So and then there's, different times a day we store, like, so insulin resistance actually causes you to store more fat, but in the places you don't want it. So that's why, like, we know that after 8 p.m. we become automatically more insulin resistant. Everybody does. It's called circadian rhythm. And so after 8 p.m., so the calories you eat at 8 a.m. are worth 30% more at 8 p.m. And that doesn't matter if you work graveyard or day shift. It doesn't matter. So you can take human cells in a petri dish, and you'll see their ability to store fat or burn fat is different whether it's 8 a.m. or 8 p.m. So we burn our calories better during the day because our bodies are designed to work. It's dark outside and we're asleep in the cave or whatever, and so if we take in any calories after that time, we're going to store it because our body wants to hold on to everything that we ate during the day because we were active and we did whatever we did for the day, and we want to actually store as much fat as we can. And so then, when you eat more of your calories earlier in the day, you'll store less of those as fat. So it's important to, not eat after 8 p.m. And I even have patients that work graveyard, and I try to work with them. Like, some of them have diabetes and stuff, and I'm like, just drink water during your shift, and then try not to eat anything during your shift. And then as soon as you get home from work at 8 in the morning or whatever, go ahead and eat. Even though you're going to go right to bed, go ahead and eat most of your calories then. And then when you get up in the afternoon, then you can eat some more and eat another meal or whatever, because now it's still before 8 p.m. But then 5 or 6 o'clock before you go back, get ready to go back to work, stop. And so you can eat as much as you want. Just make sure it's, of course, healthy food if you can, but don't eat. It's hard because I worked a graveyard shifts before I worked in the hospital and stuff, and you're just like, especially when you're tired, you just want to eat. And it's like that's the worst time to eat. And so even though you're active because you're up on your feet or whatever, even if you do like a work in a mill or something like that, you just hopefully you can just get by with just drinking water. And then some of my patients, that if they are on like insulin or whatever, they can't quite do that 100%. So they kind of, okay, maybe bring some fruit, cut up fruit or something that's low in calories, high in nutrients, high in water content. And because you might, you might, your blood sugar might get a little low or something. So you kind of feel dizzy and weak, and you check your blood sugar, it's like 60 or something like that. It's like, well, you're gonna have to eat some fruit then. So it's, so try to pick something that's at least low in calories, so it's not gonna create the problem with the insulin resistance issue, because that's when we are more insulin resistant is at nighttime. You remembered your question? We're a metabolic mess at nighttime. Yeah. And then there's all the things with, time restricted eating, try to eat between, 10 a.m. and 6 p.m. That kind of utilizes that circadian rhythm thing. So that's another thing, but yeah. Okay. On Chat GPT. Yeah. Mm. Pleasure. So it looks like given enough time of excess calories and gaining weight, then you will actually lay down more fat cells. And so hyperplasia, it's called, versus hypertrophy. Right. Right. So angiogenesis is growth of blood cells. So when you have more and more fat mass, just like a cancerous tumor, you're going to lay down blood vessels to supply blood to that tumor, to that fat. And so that's another thing. And that's what a lot of things that plants do is they block angiogenesis. So that's why that's a good thing when it comes to gaining fat and having a cancerous tumor growing in your body, is if you can suppress angiogenesis, blood cell or blood vessels being laid down to supply that tumor, you might be able to slow down the growth of that tumor. Yes, in the back. Yeah. Yeah. So I was mentioning that earlier. It's an endocrine organ. Fat is a endocrine organ considered. Yeah, because it's secreting all kinds of hormones and inflammatory markers and all kinds of things. So it is metabolically active. Yeah. Well, any other questions? Yeah, Jamie. Yeah. Yeah, so cells are individual intelligence. Yeah, they have their own cycle of what they do. And so a cell in a petri dish, when they've done this in the lab, it actually it acts differently at 8 p.m. versus 8 a.m. So it's all circadian rhythm. It's a fairly new. I mean, it's been around, science has been around a while, but it's really been cutting edge in the last couple of years. The cell it seems to function that way, and so it was totally a shock to researchers that it can do that. Yeah. Yeah. Right. Correct. So the comment was that, a lot of the cancer drugs that are out there, they got the idea for the mechanism from plants. So like one example is mushrooms. So mushrooms are high in something called aromatase inhibitors. And so there are cancer drugs that are cost thousands of dollars that are, it's a higher strength of that. But so we're not saying don't do standard cancer treatment, just, hey, with your cancer treatment and your cancer doctor, let's go for whole food plant-based diet and all the healthy lifestyle behaviors. And it's actually great because over at Willamette Valley Cancer Institute, I've secondhand spoken with, communicated with some of the dietitians over there, and they do recommend people go on a more plant-based diet because we do have a lot of good research on that for cancer survival and cancer treatment. So that's really promising, very good with that. So yeah, so it's just an adjunctive, we call it adjunctive therapy, go for that. And if you're interested in cancer, read the China study from T. Colin Campbell. It's really focused a lot on cancer and the role that plant protein or animal protein plays in cancer stimulation, development, growth. So it's IGF-1 is what it is. We think is the culprit when it comes to animal protein in cancer growth is insulin-like growth factor 1. It's a too high a level. People get too high levels of that, and that's a cancer promoter. So think of it as animal protein stimulates cancer growth, and that's what the research showed. And definitely read the China study for that. It's also talked about in Forks Over Knives, if you've seen that. So, all right, thanks everyone. We can call it a night. Oh, yeah, thank you.
Next week is, hope you can join Dr. Colgrove, pediatrician. So I know, nobody here is young, but, right? But we all have kids, grandkids, nieces, nephews, whatever. So, like to support Eric Colgrove. He does a talk on child nutrition and he talks a lot about just general. And I've learned so much from him. He's also board certified lifestyle medicine as a pediatrician. And I've learned a lot from him as far as like, gosh, I wish I would have known that when my kids were little. But it's just also it's creating a healthy food environment for your family and for kids. So it's not just about pediatric nutrition, but hope you can join next week and join with Eric Colgrove, Dr. Colgrove. Right, well, to see you here next week. All right.